Hi everyone, welcome to tonight's Instagram Live with BreastReconstruction.org. I'm Christine and I'm so honored to be hosting this conversation tonight. In just a few minutes, we're going to have Dr. Dickey and Katie Allen joining us as well. Our mission at BreastReconstruction.org is to ensure that every person facing breast cancer has the resources, community, and information they need to make the best decisions for their bodies. Tonight, we're diving into a really important topic: the TOPAZ clinical trial and the intersection of radiation and reconstruction. Before we do that, I just want to share two important events that are coming up soon. On June 7th, please join us for our Snip and Stitch event at the Full Circle Breast Cancer Recovery Program in Garden City. And then also, our Uplift annual gala and fashion show is coming up on September 24th from 6 to 11 at the Garden City Hotel. Hi, Dr. Dickey. How are you?
Hey, how are you doing? Doing well, thank you.
Good. Thank you so much for joining us.
I'm really excited. Thanks for having us.
Wonderful, wonderful. Thank you for being here. And I know Katie's just going to be hopping on in just a second as well. So I was just going over our mission and a couple of events that we have upcoming. And I'm just going to go through a quick topic and what you guys are going to be discussing. So I want to give a quick introduction to Katie Allen. She was diagnosed with a stage 2B positive breast cancer at the age of 33, just 2 months after losing her sister to cervical cancer. Originally from England, she now lives in South Texas with her husband, Cody, and their Labrador, Cooper. While they do not have children, they share guardianship of their 15-year-old niece. Following Katie's diagnosis, she also learned that she's BRCA2 positive, a discovery that helped explain her family's extensive cancer history and deepened her commitment to advocacy and awareness. Katie's participating in the TOPAZ trial at MD Anderson, where she received radiation prior to surgery. And actually, it looks like Katie is just having a little bit of a problem hopping on. Right after Katie's surgery, she underwent immediate breast reconstruction using both the DIEP and the PAP flap procedures. Outside of her cancer journey, Katie loves traveling and spending time outdoors. She and her husband are working toward visiting all 7 wonders of the world. Let's see, I know I'm just trying to help Katie get in here as well. And Katie's goal is to help other women feel informed, confident, and empowered when making decisions about breast reconstruction. We also have Dr. Dickey, who is a renowned expert who's going to help us understand the medical side of the neoadjuvant radiation and flap reconstruction. Dr. Dickey is an assistant professor in the Department of Plastic Surgery at MD Cancer Center. He earned his medical degree from the Baylor College of Medicine and completed residency in plastic surgery at UT Southern Medical Center. Dr. Dickey then completed a fellowship in microvascular reconstructive surgery at MD Anderson. He specializes in complex microsurgical reconstruction with the clinical focus in autologous breast reconstruction. He's received multiple awards for excellence in research and teaching. Known for combining technical precision with compassionate care, Dr. Dickey is committed to delivering excellent outcomes and advancing reconstructive techniques. So Dr. Dickey, I think we may have to start with you quickly, since it looks like Katie's having a little bit of a challenge hopping on. So Dr. Dickey, let's just start with you. If you want to just start with some of our questions. When a young patient presents with breast cancer and a known BRCA mutation, how does that impact the treatment, the planning, and the reconstruction options?
Well, thanks again for having me here and setting this up. I think Katie's case is very interesting, both in that she had cancer, she had a genetic predisposition for cancer, and she was young. And as you mentioned, she had not yet had children yet. And there are a lot of factors that go into deciding what type of reconstruction somebody needs and wants. I think that when you're thinking about a young patient, you have to have a reconstruction that's going to last for several decades, because we are planning for full treatment and remission. And so we need to have a reconstruction that's going to last into at least 40, 50 years. And I think that's where having the tool set of microsurgical reconstruction is so helpful, because we can deliver a natural reconstruction that really should last her whole life. The other consideration in a young patient is young patients who may or may not have children don't have the same abdominal donor site potentially that somebody that has had children. C-section, may have additional, has had surgeries for the abdomen, but essentially has the general postpartum physiology where you've got a little bit of tissue redundancy, sometimes a little bit of extra skin. And somebody who's young, hasn't had kids, that generally you don't have the same type of body habitus. So that's a consideration in young patients. Sometimes you have to add additional flaps like we did in this case. Sometimes you have to go to other donor sites from other parts of the body. So these are all things that we talk about in the initial consultation. And I think the key is that every patient really is an individual, and we try to tailor our reconstruction to that patient, whatever that patient's goals are, what their fears are, what is most important to them. And so it's a patient-centered decision making. And I feel like my job is to present a suite of options that I think would be reasonable given the circumstances.
Okay, great. Thank you. And can you explain what the TOPAZ trial is and why the radiation before surgery may be recommended in certain cases?
Yes, the TOPAZ trial is a very interesting trial at MD Anderson. I think the history of this is really the brainchild of one of my partners, Dr. Mark Shavrin, as well as collaborators in radiation oncology. I think that the concept with TOPAZ is we wanted to have some of the advantages of immediate reconstruction. So that would be having an autologous reconstruction at the time of mastectomy instead of doing a tissue expander replacement as an intervening step. But we wanted to avoid the issues of applying radiation to a fresh free flap reconstruction. That can be done, but I think there are many drawbacks when we radiate flaps that have already been reconstructed. They can shrink, they can change in size, fat necrosis, there are a whole host of issues. So the way around that was to switch the order of when radiation happens. That's really what TOPAZ trial is. It's a trial of preoperative radiation. What we do is we borrowed from a technique and used in other cancer surgeries, such as sarcoma surgery, where the tumor receives radiation first, and then the patient undergoes a mastectomy with immediate reconstruction. So it's immediate, but the flap itself doesn't get radiated. So this is a trial that is currently enrolling at MD Anderson. And we are trying to understand its benefits and risks, both from an oncologic and a reconstructive standpoint. But early results are very good. Hey, Katie.
Wonderful.
Hi, I'm so sorry. I was having such issues joining. I don't know why it kept expiring, but I've been here and I've been listening, and yeah, now online as well. So apologies for the technical hitch.
Wonderful.
We're just glad to
Katie.
have you.
So glad you're able to join us. Thank you so much. And Katie, we went through your bio before and your history. So we just switched a little bit and we started with Dr. Dickey with some of his questions. Dr. Dickey, if you want, we can go and work through Katie and she can talk about some of her journey.
I think we're all here for Katie.
I agree. Sounds awesome.
I don't know about that.
Sounds great. Let's go back to Katie for a little while. Again, Katie, thank you so much. And your story is just really inspiring. So, Katie, just tell us a little bit more about your journey and about your diagnosis.
Yeah, of course. There's a lot of cancer in my family. We are not strangers to it. And my mum and her sisters had previously thought that they had been tested for BRCA. Turns out they weren't, but that's a whole separate issue. And so my sister was actually diagnosed with cervical cancer, and she was undergoing treatment for that. And so I came to my PCP here and I was like, hey, I just want to do like an MOT. I want to do a body check, just make sure I'm all okay, because my sister's diagnosis came totally out of the blue. And so I knew that nothing really at that point is off the table. So luckily I have a fantastic doctor here locally, and one of the first things that she did was send me for a mammogram. And I actually had to delay it a couple of times because I had to travel back to the UK, and my sister passed away in March last year. And so I came back, and I think I'd been in the country for 3 days or something, and I went for this, and it flagged it as an architectural distortion, and I got recalled for a diagnostic and an ultrasound and a biopsy, and I'm coming up, actually my 1 year since diagnosis is next week. So yeah, that kind of really just got the ball rolling. And I think that you're never fortunate to get cancer, but I think I am incredibly fortunate that it was caught. And I honestly believe that being in the US is a big part of that. I don't think it would have been found if I was in the UK because I didn't have any symptoms and I was already a stage 2B. So that was incredibly lucky. And the fact that we're only 4 hours, which in American driving time is absolutely nothing. So we're only 3-4 hours from MD Anderson in Houston, where I've been able to be treated and very fortunately got assigned Dr. Dickey as my plastic surgeon.
Awesome. And Katie, how did losing your sister so shortly before your diagnosis really shape how you processed everything?
That's a really good question. I would say that I probably still haven't processed anything. I think because when my sister was going through all of her treatment, I tried to be as present as I could for her. Like I took her to chemo sessions and all the rest of it. So all of the terminology, that wasn't a new thing for me. I was already geared up to navigate it quite well. And so when they told me that, they called me and said, yeah, your biopsy's come back and it's cancer, I was like, okay, great, what's the plan? I've not been emotional about it at any point. I'm just very pragmatic. And I think it's probably just partly being numb to it all, if I'm honest, just because of having to deal with my sister's cancer and then the loss of my sister. This really, in comparison, was very manageable.
Yeah, and again, I was so sorry for the loss of your sister. What else, Katie? What was it like learning that you're BRCA2 positive, and how did that information change the conversations that you had about the treatment and the reconstruction?
Yeah, so I was already pretty keen on having a double mastectomy just straight off the bat because my view on it has always been just to take a very drastic and aggressive approach. Obviously, that doesn't necessarily mesh with the guidelines now. If you don't have that genetic predisposition, a lot of the guidelines and the advice will guide you more towards a lumpectomy and conserving surgery, which I was very on the fence, to be honest. My breast oncology surgeon made a very good case for it. And then once I got the genetics, that to me was just a blanket full double mastectomy, no other choice really. That was the decision. And I think for me anyway, that was going to be the best choice. It gives me the best peace of mind. And then it's obviously had implications in terms of my medications long term. So I'm currently on a PARP inhibitor, and that is related to my BRCA status.
Okay, thank you. And what led you to participate and explore the clinical trial, the clinical TOPAZ trial at MD Anderson?
So ironically, I'd actually met a gentleman here in Corpus Christi who had been treated at MD Anderson years ago for, I think it was leukemia or Hodgkin's lymphoma, sorry. And he was like, oh, have MD asked you to be in a trial yet? And I was like, and he was like, don't worry, they will. And it was probably about a month before I got offered it. And I think I'd come in for just pre-meetings and just general checkups and things. And Dr. Dickey actually didn't mention it. It was my breast surgeon, Dr. Liang. And I found it incredibly overwhelming. I wasn't prepared for it at all. And it was really the first decision that I'd had to make in my treatment plan. Because before it was very much, this is the chemo, this is, you're getting your port, and then you'll do your chemo, and then we'll do the surgery and the radiation. So the choice to do the trial was actually really challenging for me because I didn't want to choose wrong, essentially. And I actually connected with someone on Reddit who is now a very good friend, and she had also been offered the trial and was looking into it. And I think she'd probably been a little bit more open than I was when it had been brought up in discussion. And some of the facts that she then shared with me that she had learned from her team encouraged me to open the door on those conversations. And I looked at the data and I asked for some more information. I was very much on board. It took me about a week, I think, to gather myself and really come to terms with having to make a choice and then sticking by that choice. And I think part of it was like my sister's voice in my head, probably just being like, I know she would have encouraged me to do it. So that was definitely a bit of a persuader.
I had that guardian angel you felt guiding you along, right?
100%, yeah.
What questions or concerns did you have going into radiation before your surgery?
To be honest, I feel like I had a better edge, really, because I think that for the women that have surgery first, you have very restricted arm movement, particularly if you've had an auxiliary lymph node dissection. Like, raising your arm is very challenging, and you have to hold that position in radiation for 20-30 minutes 5 days a week for 3 to 6 weeks. And I didn't have any limitation restrictions, so that was incredibly helpful. And from the skin and the tissue perspective, to be honest, I had some kind of concerns and thoughts around it, but I discussed it with my radiation oncologist and with Dr. Dickey. And honestly, I think having such faith in my plastics team goes a very long way, because I trust Dr. Dickey a lot and his team, and they've done incredible work. And everyone I've met that has also had Dr. Dickey as a surgeon just absolutely raves about him. I felt very confident in my choice at that stage. So the radiation before surgery actually wasn't even that concerning to me.
Sounded like you knew you were in good hands then.
Definitely, yeah.
What questions, really, was there ever a moment where you just felt just really overwhelmed with everything that was going on? And how did you help process and get through all of it?
I honestly think the only overwhelming time I've had during treatment was when I had to make that decision about the trial. My husband likes to joke that I was bred for this, because there's just so much cancer in my family that none of it is a shock. The surgery, the chemo, like, we're used to it. We've got the ice mitt booties and things for Taxol, like, we know all the little hacks. So I've not really struggled to process it. I think I've had maybe a few more kind of questions or challenges navigating the post-active treatment as opposed to the active treatment portion of it. And I've actually found a specific AI system which is designed for cancer patients that I use, which is Radical Health AI. And I found that incredibly helpful to navigate really just the little questions that I don't want to bother my team with, that it's not really on anyone's radar if I can have lion's mane or if that interacts with any of my meds.
Great. I love to hear how you're using all the latest technology as well. My next question was just really going to talk about focusing on recovery. Besides what you just said, was there anything else really about your recovery that surprised you the most, either physically or emotionally?
So I don't want to set any false expectations for anyone, but I feel like I was remarkably lucky in my recovery. I know Dr. Dickey can probably talk a little bit more about on the blockers and stuff that I had during surgery, but I really didn't have too much pain, if I'm honest. I think by day 2, I was just on Tylenol and a muscle relaxer. And I found the muscle relaxer really helped me a lot more than anything a bit more hardcore like the tramadol or the ox. It was the Robaxin genuinely really helped me. And I found I was looking back through my notes on how I felt post-surgery, and really it was more feeling achy and sore, particularly in the afternoons. And then what I did get was I found out very quickly if I was moving incorrectly, because I would get quite a sharp kind of burning pain on my abdominal incision if I tried to get out of bed wrong or off the sofa or something. And so that was a pain-guided learning curve, but it was very kind of short bursts, which was very manageable. My biggest bugbear, honestly, after surgery was the drains. I had a lot. So because mine was a stacked DIEP and PAP flap with the double mastectomy, and it was all in one big 13-hour surgery, I came out of that with 8 drains and I went home with 6. So the 2 and I had 1 coming out of each leg, and that was not particularly fun for me. They were not great. I had those in for at least 4 weeks, and yeah, that bit was my least favorite.
I'm sure. How did reconstruction impact how you felt about your body and healing after cancer?
So I'm very much a look on the bright side, a little bit of dark humor. So I wouldn't want to offend anyone in the terminology that I use. I very much am seeing this as a silver lining of cancer is that I'm basically getting my summer body, and my stomach has never been this flat. I don't think my boobs have ever matched this well, and I got lipo 3 weeks ago. So all of those things are a massive win for me. And honestly, the scars, obviously I have scars, but they're healing great. And like Dr. Dickey very kindly revised my port scar, which was pretty gnarly, to be honest. I had some challenges with that when it got put in last year. And the revision on it, like I can barely see it, to be honest, now. So yeah, I'm loving my post-reconstruction body, if I'm honest.
I love hearing that. And I love how you took not a positive situation and you really turned it around, like you said, with that. And I think a great attitude and positivity really certainly helps with your really emotional and physical healing as well. So I'm glad to hear that. How did your support system, including your husband and your niece, how do they help you through this journey?
My husband has been amazing. He really has. He's come to all my appointments. I got a lot of my chemo locally, so I didn't have to travel MD for it. And I honestly think my local oncologist just really wanted to see my husband, to be honest. They just chatted about football. I think I was just there to justify it. But he's been incredible. And after surgery, he would strip my drains. He took very good care of me. And my niece is actually in the UK, and she flew out for the summer last year. So she was here through some of my chemo, and we didn't let chemo stop us. We went tubing on the river, we went on adventures, and still very much tried to stay positive and active throughout that. And our friends here in Corpus have been incredible as well. They've really pitched in and taken care of me, and when we've come up to Houston for appointments, they very sweetly look after our dog, and just being there in all the ways. I've got little sticky notes all around my apartment even now from a friend who came and wrote little motivational quotes, which was incredible. And my mum also flew out from the UK for after my big surgery in December, and so she was here for my auxiliary lymph node dissection and lymphovenous bypass in January as well. So that was really lovely to have her here too.
That sounds wonderful. And I have no doubt that you were out there celebrating life and loving every minute of it with the support system and just enjoying your recovery journey. So thank you for sharing that.
Oh, my pleasure. My only downside is that I was very optimistically meant to be running in a relay marathon in a couple of weeks. And I think I'm only going to be at my 6-week post-op by about 2 days. Today, I have relinquished my place on the team so that I don't let anyone down, because that would probably be pushing my luck a little bit. But otherwise, apart from that, I'm definitely still trying to have a positive mental attitude and just really just get on with everything as normal and keep at it. Yeah.
And Katie, after hearing this incredible story, I don't think anybody is going to feel that you're letting them down. So get those thoughts out of your head, because I really don't think that anybody's going to think you're letting them down. And again, I think they're going to find you really inspiring. Looking back, Katie, what do you wish that you had known earlier?
That's a good question. I think having an understanding from a patient's perspective of what post-surgery can look like, because I'm in a lot of like Facebook groups and I'm active on Reddit and places like that, and everyone's experience is so different, and a lot of the time people will share it if they've had a really bad time of it and the challenges and kind of everything like that. So I feel like having more positive stories of how people have dealt kind of post-surgery and during treatment and things is really important, because like for me, like I very nearly bought a very expensive, very large recliner chair because apparently it was the absolute must-have after having this surgery. And I basically ran out of time because we went on holiday instead. and that worked out for the best because I didn't actually need it. So I think having positive stories to base off of and have a variety of expectations. So it's not all doom and gloom. With the right team and the right medication and the right approach, like it is all very manageable.
Awesome. Thank you for sharing that. What would you say if you can offer some advice to somebody who is newly diagnosed, just completely feeling so overwhelmed with choices? What advice and what would you say to them?
I would say get as much information as you can in a way that you can understand it, because there is so much information thrown at you when you're first diagnosed, and obviously everyone's paths are different. Some people have surgery before chemo, and there's a lot of information there to take in. And I think that having it in a way that is digestible and understandable to and relevant to the stage that you're looking at is really important, because if you're informed, you can make a better decision. So, for example, going back to when I had to make a decision on the trial, when I felt overwhelmed, I wasn't informed about it and I just blocked it out and stepped back. And then as soon as I made myself informed about it and I got that information and I understood it and what it involved and what it would look like, then I was able to process it and actually see that it would be to my benefit. So I think getting what you need to know in the right way and in the right amounts, I think it's very often that people will just open the floodgates and try and learn as much as possible. I remember back in July last year, I was looking at what medication I would be on now, when really I had so much more to focus on at that time. But yeah, I think just being as informed as possible about all the options is really important. So I think I'm going to have to go back to my memory here, but I think at the beginning I was like, yeah, I'll get implants. And then Dr. Dickey showed me the data. We had conversations about how actually the best results come from, and I can never say this word, autologous reconstruction. So having that information again was able to help me understand and pivot and make the best choices for me.
Thank you for sharing that. And Katie, why is it so important to share your story with other women? And how has that helped you process everything that you've gone through in the last year?
I think it's so important. So I think because I didn't have any symptoms, I'm very much everyone needs to get checked. You need to know your baselines. You need to know your body. Just as a starting point, I think there are so many women who almost don't do regular checks because you're scared of finding something, and whether that's breast checks or you're avoiding a pap smear, whatever it is, trust me, having the mammogram or having the pap smear is better than having chemo. So it's in your interest to do those checks. And so I'm very vocal about that and just raising awareness, and the fact that cancer doesn't discriminate based on age. A lot of guidance and a lot of textbooks and a lot of screening is aimed at women who are 50, 60 plus. And I was 33 when I was diagnosed. My sister was 36 when she passed away. Like, cancer doesn't discriminate. Raising that awareness at a younger age group, I think, is really vital, and understanding your options. So again, like, I wouldn't have really considered the autologous flap as an option. I was very set on implants until I opened that door. And I think that making yourself informed about all of the options and what might be the best outcome for you, and what your surgeon is particularly good at. Dr. Dickey and his team are fantastic at these types of surgery, which I can vouch for. I'm sure you're very good at all the others as well, but like this one in particular, I can firsthand say is excellent. So I think making sure you're comfortable with your choice of reconstruction and then your team to do that is really important.
Thank you so much, Katie. That was, again, just such an incredible story. And thank you for sharing that with everybody. And Dr. Dickey, I'd like to go back to the more clinical aspect of it now. And again, feel free to jump in anytime. But if you could just explain to everybody the difference between the DIEP and the PAP flap reconstruction in simple terms.
Yes, absolutely. So I think most people are familiar with DIEP flap, but that is just an acronym for inferior epigastric perforator, and the abdomen. So what we do is we grow tissue from the lower abdomen, similar to like what's taken away in an abdominoplasty. We have it so that it's We use that for to recreate a breast. It's as simple as that. In terms of PAP flap, stands for profunda artery perforator. That is a small blood vessel that's in the thigh region. So that is a free flap that comes from the upper medial thigh. There's a few different ways you can design that flap. For Katie and for most patients, I like to use a transverse design which hides the scar in the buttock crease. So it's less visible if somebody wears shorts or a bathing suit. You can also design it in different ways. So that's something you can talk with your surgeon about. But DIEP and PAP is really just using tissue from the abdomen and from the inner thighs. There are other options for breast reconstruction. I think at MD Anderson, we offer really the full portfolio of perforator breast free flap reconstruction. I would say lumbar artery perforator would be another option that works well in thin patients. It's a complicated surgery as well, but I would say like lumbar and a stacked deep PAP equivalent in terms of the volume they can give you. But I think in Katie's case, I think this made the most sense considering the immediate reconstruction element. So that's it, thigh and abdominal tissue. We borrow tissue from wherever a patient has it. If it's all in the abdomen, great. If some patients carry a lot of subcutaneous tissue in their thighs, then we go with that. If it's in their love handles, we go with that. It is a patient-centered design.
Thank you. Thank you for sharing. How does the neoadjuvant radiation affect reconstruction planning and the outcomes?
Yes, this is the TOPAZ design. The neoadjuvant radiation concept is relatively new. We've been doing it, I think, for a year or two at MD Anderson. So we've learned a lot of things. I think that the first consideration is radiation delivers energy to the breast tissue, and then the consequences of that can take several months to even years to be fully realized. So there's this element of a moving target in the TOPAZ trial where the breast that's been radiated is going to go through additional changes over time. Things like atrophy can get a little bit smaller. It can get a little bit tighter. Sometimes it can shift upwards. So the concept being it's not necessarily scar tissue, but the pocket is tight. It loses its elasticity, loses its tissue compliance. So for those reasons, you have a moving target that we have to try to match now with the other side. So those are the things I think about. What am I going to do on the other side to make sure that we can match? How am I setting up the breast for additional revision surgeries to make sure I can match things if things continue to get asymmetric in the future? So that I think that's the main thing. The other element is, at least in the literature that we are, or in the data that we're generating, there's a slightly higher rate of like mastectomy skin flap necrosis at the margins of the incision in TOPAZ patients. That can vary in severity from a small scab to something that's a little bit bigger. I think that's why autologous reconstruction makes sense, because we can heal the tissue underneath that and we can do surgery to try to adjust that. But that's the other thing that you have to plan for, that if the skin flap isn't looking very good at the time of surgery, that you need to plan for your potentially new skin from the donor side. So the other element that you have to consider in TOPAZ.
Thank you. And what should patients know about recovery time expectations and long-term results?
Well, I think Katie's case is, I think she's a remarkable patient and a remarkable person. I think her recovery was definitely better than what I had expected, meaning she was in very little pain after surgery. I wish I could take the credit for that. We do a lot of things to try to reduce pain. We use long-acting numbing medication called Exparel. We use multimodal pain agents to try to treat the pain. Anesthesia is doing a lot of stuff to try to also get anti-inflammatories and pain medications on board. So we do a lot of things, but I would say everybody's experience of pain is very different. Some patients may be okay with Tylenol, others are in a little bit more pain. I would say just in general in my practice, I tend to say you're going to be in the hospital two to three, potentially 4 days after surgery, especially surgery like this, maybe a little bit longer. But patients are up and walking post-op day one. We see generally you're over the hump of a lot of pain after about a week or two and able to do kind of light activities. Some patients run errands. If they're not quite ready to drive, they can at least go out and walk around and do errands, that sort of thing. I think overall, the recovery to going back to normal is probably somewhere in the 6 to 8 week range post-op, where you can swim and start to gradually increase exercise activity. That's what I tell patients. I think that's what we see. Katie can give a lot more nuance to that. Feel free to jump in. And then I would say once a patient's healed, if they need a touch-up surgery or around 3 to 6 months You can have additional revisions if those are needed. And then I think once you're healed, it's a reconstruction that's going to last a lifetime and will age with the patient.
Thank you. And I know I reached out to Katie, I believe like a day or two after her surgery, and she was like, I'm feeling great. And again, really remarkable. And Dr. Dickey, what's the most common misconceptions about breast reconstruction?
I haven't been on the other side of this, although my mom did have recognition and bipedical deep flap reconstruction, but I've been through it as a family member. I think that breast reconstruction it's very complicated and it's a process. It can take a long time for some patients. It can require a few stages. I think we try to limit the number of surgeries that are needed to get a great outcome in terms of efficiency of our sequencing. I try to do it in 2 to 3 surgeries. Sometimes it can take an additional surgery. I think I like to think about, especially autologous breast reconstruction or natural tissue reconstruction, it's like building a house. So you've got to lay a foundation, you have to then build the house, and then you put in all the elements that make it a beautiful home. And once it's completed, it's yours, but it takes a while. It can take months to some patients it's a year plus if somebody has radiation and has adjuvant chemotherapy that they have to go on. So we can work with patients no matter what is required. And so I think understanding that it's a process it's important for patients to understand that, and that's something breastreconstruction.org is doing a lot of work on to help educate patients. I also think that, like Katie mentioned, there are a lot of decisions, a lot of important decisions that have to be made in a relatively narrow window. And that's very stressful. It can be very emotional. And depending on patient support system, it's just very difficult. And I think it's important to have a surgeon and a team that can guide you through that, and also that can offer different options for breast reconstructions, hopefully all of the options. There are implant options, there are flap options, there are different types of flap options, different types of implant options. So I think particularly in patients who may not have enough tissue in the abdomen for deep flap, which is certainly the most common operation we do, we've got to do other things, whether that's adding a stacked flap or going to an alternative donor site. And if you feel that might be applicable to you, I think it's important to potentially identify a team that has experience with kind of those other options. Certainly at MD Anderson, we have 30 microsurgeons who are experienced with all of this. I think that's one advantage for a large center, but there are lots and lots of excellent surgeons who can take on those kind of patients.
Thank you. And you answered this question a little bit, but if there's anything else you want to add, what advice would you give to the patients who are unsure if reconstruction is right for them?
I think importantly, finding a board certified plastic surgeon who is focused on breast reconstruction, I think is a good first step, and one that you feel like you have good rapport with, that is a teacher and can act as a guide for what your goal outcome is. I think advocacy websites like breastreconstruction.org, as well as several social media advocacy and support groups, are excellent sources of information. We are actually studying, along with UT Austin, the use of AI, like Katie mentioned, generative AI in its role in helping patients gather information about breast reconstruction. I think that anecdotally, like when patients search on Google, search on the internet, a lot of times they find things that may be scary or not that helpful because potentially someone has had a complication or has had issues. I don't really like that. I think the patient advocacy groups give a rounder picture, I hope. There are patients who may have had complications that generate a lot of content, which it's important to understand, to know that and understand. There's patients that have had really great results that also generate content, but there's probably more patients that have had excellent results that don't generate a lot of content. So I think that's also important, and that's why I applaud Katie and others who are so passionate about this. Yeah, but I do think AI is going to be very important. We've actually validated that it's accurate to generate questions to ask surgeons about breast reconstruction. So I actually recommend my tech savvy patients go on ChatGPT, bring a list of questions, tell me what you've learned. We kind of go through all of it.
That's really incredible. And Dr. Dickey, thank you for really answering everything from that clinical perspective. Katie, is there anything else you want to add to anything that Dr. Dickey just said?
The only thing I think would be to just say that, yeah, if anyone's got a surgery coming up, don't be afraid to ask your surgeon questions. You have to have, like you say, that rapport and that trust in them. grill them. Like, I think the first time my husband and I met Dr. Dickey, my husband was asking you how many surgeries of this type of surgery have you done, and wanted to understand that. And that is totally fine to ask, to get that understanding, because that is part of you having the trust in your surgeon. And also from the flip side, from the patient side as well, I would say, like, I'm very open about obviously everything, all my surgeries and everything, and I am more than happy for like my pictures to be shown to prospective patients, because I think it's really important as well for patients to be able to see what their outcomes may look like, which not everyone does, and that's totally fine if no one wants to go down that road. But I think it is important for women to have that understanding of what your body may look like at the end of that. And when you come to the end of your surgical process, if you are able to say, yes, that's fine, your face isn't in them or anything, and no one knows it's for you. But I think that's actually a really important thing to do as a patient, to benefit patients down the line, so they can see that and weigh it up and figure out if that is the route for them.
Thank you. And I think really just listening to the both of you tonight speak, it really just shows, Dr. Dickey, the importance of the bonds and the trust that your patients have in you, and how you seem to just make them comfortable with you. And Katie, just about advocating properly and really just asking the right questions. And again, just developing that relationship. So it's been incredible hearing from both of you, from both the clinical and the personal side. So thank you, guys. And I'd just like to take a few questions if you guys have a couple more minutes. Great. Okay. So one of the questions is, was your surgery nipple scarring?
No, it wasn't. For me, my decision was anything that carried any type of additional risk just needed to, I didn't want to keep it. I was like, I'm quite happy with the scars. I'll get tattoos down the line when we're done with surgery.
Got it. And after reconstruction, they're asking, are we able to do push-ups and pull-ups, and what types of exercises?
Have you done any push-ups, Katie?
I have not yet, if I'm honest.
Yeah, once you're healed, so I would say at that 6 to 8 week mark, pull-ups, push-ups would all be fine. Yeah, I would go gradual. So if it was 0 before surgery, maybe just go slow.
Don't just jump right into it.
Yeah.
And who are the ideal candidates for this type of surgery?
The way I think about it is, does a patient require additional volume or in addition to the abdomen in order to get their goal size? So I would say a typical patient who undergoes stacked pap DIEP or floor flap breast reconstruction is generally probably on the thinner side, could be somebody who does not have children or hasn't had kids, somebody who wants a goal size that is at or even larger where their current bra size is. And then somebody who has the available donor site from an anatomic standpoint, hasn't had abdominoplasty or other surgeries that may have injured blood vessels, et cetera. So that's something that your surgeon can help identify. And then for the TOPAZ trial, so this is a trial ongoing at MD Anderson. So the criteria are patients that require mastectomy and radiation are basically, and then with certain tumor types are asked or screened for it and then asked if they want to participate in the trial. If not, then they would undergo standard of care treatment, which would be post-mastectomy radiation therapy.
Thank you. And I think that looks like all of the questions that we have tonight. Katie or Dr. Dickey, do you guys have anything else that you want to add to our conversation?
I might just add that also, if you're a little bit on the thin side, you can gain the weight for the surgery, because I had to gain 15 pounds. And if I'm honest, it's rather rude, because after my mastectomy, I only lost 3 pounds, which apparently is how much my boobs weighed. So I had all this extra weight that I'm still trying to work on. But yeah, you can also gain the weight for the surgery.
Thank you. And Dr. Dickey, do you have anything else that you want to add?
I just want to say thank you to both of you, and especially to Katie, for your courage. I think you're an inspiration to, all of us at MD Anderson, and we just look forward to what you do next.
That's only because of my accent.
10%.
And I certainly do agree with that, Katie. Your story, again, is just so inspiring, uplifting, your resilience, your courage. It's really incredible. And again, thank you both and everybody who's joined us tonight for taking the time out of your schedules. We really do appreciate you joining us. We do have an IG Live every month. We will have some more information on our May Day coming out soon. Just a quick reminder, we do have our 2 upcoming events as well. June 7th, we have our Snip and Stitch events in Garden City. And on September 24th, we have our Uplift annual gala and fashion show as well. Our website is breastreconstruction.org. Definitely hop on over to our website, check out all of the resources and the tools. We will have this video posted as well on our website within the next couple days. And again, just thank you guys so much. And Katie, our thoughts are with you for just a great recovery to continue. And we look forward to hearing from both of you again soon. So thank you so much.
Thank you so much for having us.
Thank you. Have a
Bye,
great
guys.
evening.
Thank you. Have a great night.
Bye.